This presentation will not be given in class, so please read your book and listen to this voiceover. Certainly, if you have any questions, don't hesitate to ask your instructor. Many different mechanisms of injury can result in eye injuries. Examples include burns, abrasions, lacerations, and impaled objects. Due to the impact eye injuries can have on quality of life, they are all considered high priority cases. A large population of Americans suffer eye injuries every year, and most of them could have been prevented if protective eyewear was used. Many injuries are due to job-related accidents, such as welding or woodworkers. Sports are also a common mechanism of injury. This slide provides some examples of common eye injuries, either in the workplace or at home. Prevention is key to maintaining this precious sense. This eye injury is extremely common, yet many who suffer the ill effects of this never seek treatment. They typically occur due to small foreign bodies such as an eyelash trapped in the eye or contact lenses. It is a very painful injury, as I can attest, with the patient experiencing photophobia and tearing. Diagnosis is commonly made using fluorescent drops and a slit lamp. Physicians will typically remove the small foreign body through eye irrigation or a sterile cotton-tipped applicator. I am not so sure this example required an arrow. It's pretty obvious. If the injury is deeper than the epithelial layer, antibiotic eye drops may need to be used. Typically, some type of eye shield will be used and kept in place for at least 24 hours to rest the eye. The most common mechanism of injury for burns to the eyes are due to chemicals. Believe it or not, alkaline burns are much more serious burn as compared to an acid. There could be an extended period with this burn, so it is vitally important to immediately irrigate the eye with large amounts of normal saline when these burns occur. Irrigation should occur for at least 30 minutes. The patient may present with reddened and edematous conjunctiva and a cloudy or hazy cornea. Once irrigation is completed, antibiotic drops are prescribed, and the eye tends to be patched to prevent excess movement and augment healing. This chart will review with you the easiest way to continuously irrigate an eye. Fluid should be directed from the inner corner to the outer canthus of the eye. Make sure to prevent the other eye from being exposed to the irrigant, as the other eye can suffer the same effects of the burn. Irrigation is continued until the pH normalizes. This type of injury does not need to be defined. Many things can penetrate the eye. There is typically one entrance site. Whatever has embedded itself in the eye, it is important to immobilize it so as not to cause further damage. Do not place direct pressure on the eye when attempting to immobilize the object. Once the object is removed by the provider, the eye will be irrigated and patched. Patching the unaffected eye will reduce eye movement altogether. Antibiotic ointments will be ordered. Surgery may or may not need to be performed. In a penetrating injury, there is one single entrance wound and the layers of the eye reapproximate, which basically means it heals itself and the wound comes together. While in a perforation injury there is an entrance and an exit site, it is much more profound. The layers in the eye do not reapproximate. In this type of injury, there is a rupture to the globe and there is a potential for permanent loss of sight. There may also be the potential that the patient loses the eye. In blunt eye trauma, as in all types of blunt trauma, there is no penetration. In this case, there is no penetration to the eye. Common mechanisms of injury to the eye considered blunt trauma are contact sports-related injuries or being directly hit in the eye with a baseball, for instance. The result is essentially a black eye. In some cases, there are small subconjunctival hemorrhages that heal on their own. The patient does not typically have pain. Hyphema, which is bleeding into the anterior chamber of the eye, is also a potential injury. In this case, the patient will complain of pain and decreased visual acuity. In the worst case scenario, the patient may experience an orbital blowout fracture. The ethmoid bone at the base of the skull is the most commonly fractured bone. Components of the eye may herniate through the fracture site. The patient will complain of pain, diplopia, and an inability to move the globe upon physical exam. A sunken eye or endophthalmos may also be noted. These patients are typically placed on bed rest with their heads in a semi-Fowler's position. The unaffected eye should also be patched to prevent eye movement. Healing should occur in 2 weeks. When the retina detaches from the chronoid, the patient has a retinal detachment. This is usually a spontaneously occurring event, and most of the time is a result of the normal aging process. The vitreous humor shrinks and pulls the retina from the choroid. Vitreous then enters the defected area. As the defect increases in size, more vision is lost. If reattachment does not occur within a short period of time, the neurons of the eye become ischemic and die. This will cause permanent vision loss. Typical signs and symptoms of retinal detachment include floaters within the visual field and the feeling of curtains being drawn across the visual field. Upon visual assessment, the eye appears perfectly normal. The patient experiences no pain with this injury. As common to any complaint by the patient, nursing assessment is always the first step. In many cases involving the eye, this needs to be completed very quickly. Ask the patient about current eyewear or contact lens use. Are they aware of their normal visual deficits so a baseline can be established? Eye movement and pupil assessment, part of the cranial nerve exam, is completed. Especially for blunt trauma, you must rule out underlying head injury. So begin with the ABCs of trauma care. In this instance, once you get to mental status, you are now on D for disability. Obviously, in this list with a retinal detachment, ineffective tissue perfusion overrides pain in all instances. Patients with retinal detachment, remember, do not have pain, but they have the potential of ischemia to neurons in the eye, so that makes that a higher priority. Generally, the following interventions are carried out on all patients if an eye injury is suspected. If the patient wears corrective lenses of some type, glasses or contacts, they should use them for the exam. At least then you would have a baseline. Especially with multi-system trauma, inspection of the eye is not at the top of the list for assessment, but at some point it does need to get done. With painful eye injuries prior to exams, anesthetic drops should be used. If your patient has an obvious burn to the eye, irrigation trumps assessment. Irrigation must occur as soon after a burn to the eye as possible. With larger foreign bodies, stabilization of the object must occur, and the patient encouraged to rest will reduce damage. If able, an eye patch will be applied to prevent eye movement. Once treatment is completed, it is important to teach the importance of eye shield wear to rest the eye. decreased activities as the eye heals, and to avoid activities that have the potential to increase intraocular pressure. For injuries to the eye, such as a corneal abrasion, antibiotic eye drops and rest may be the only treatment. Please remember prior to discharge to teach the patient how to instill eye drops. May also want to review this on our own. Steroids may be used to decrease inflammation. Also, an anticholinergic drug such as atropine drops can be used to dilate the pupil and decrease the pain. Penetrating and perforating injuries may require opioid use to reduce the pain. If nausea occurs either due to the pain or pain medication itself, an antiemetic may be used as vomiting will increase intraocular pressure. A carbonic anhydrase inhibitor such as acetazolamide, which is also known as Diamox, may be used in patients with blood trauma to decrease intraocular pressure. As stressed earlier, the quicker you can seek treatment for a patient with a retinal detachment, the better. It is important to position the client, so that the area of detachment is inferior or at the bottom. This pushes the retina in closer contact with the choroid until the area can be repaired. These patients are typically laid flat, so monitor those cardiovascular patients carefully for difficulty with breathing. Keep your patient, and yourself for that matter, calm. Reassure them that with prompt treatment, this condition is curable. Surgery is the only intervention that will correct a retinal detachment. There are many options to the patients today. Post-op, the patient will need to rest the eye and make sure they limit any activity that can increase intraocular pressure, like bending down or straining with stools. Basic care and comfort. This concludes this presentation. Please don't hesitate to direct any questions to your lead instructor. Thank you.